I have to admit, when I received this title, I got kind of scared. And what you usually do, you go to PubMed and try to find literature, and I couldn't. So these are my potential conflicts of interest. And what I actually did, I went back to a concept which was expressed more than 30 years ago by Martin Tobin in JAMA. And he summarized the major aims or goals of monitoring. And please note that alerting of significant changes in patient's condition. 1, providing institution of life-saving measures. 2, aid with diagnosis and therapy. 3, and assessing therapeutic response, and eventually predicting prognosis. Now, I tried and will present you a few case reports from my institution, and I will try to convince you that beyond monitoring, that we in general consider as something that is related to a specific event in the immediate timing in which it occurs, there is a role also for 24 hours, and if you want, 48 hours data analysis. Let me start from a well-known consideration. This is a cohort study published in the Blue Journal a few years ago, where the authors showed a high rate of arrhythmias in patients with sepsis and an even higher rate of arrhythmia in patients with septic shock. And this was related independently on mortality and on prolonged length of stay in the ICU. Now, this is my first case. He was a 66 years old patient. He presented to the emergency room with a status epilepticus with no previous history of epilepsy. And he was intubated immediately in the emergency room, underwent a contrast CT of the head that showed a right parietal temporal mass. The patient started a therapy with levetiracetam. I'm sorry, I usually use the commercial name of the drug. And he was sedated and paralyzed, and then we started to reduce sedative IV drug. And we observed during the day repeated episodes of paroxysmal supraventricular tachycardia, which increased after ICU admission. And here, in the lower part of the slide, you have a summary of what happened in the 24-hour. And so we had different episodes, and we had a broad range of heart rate that was related to these episodes. But let's look at the shape, at the description of the 24 hours heart rate report. You see in the first row, day 1, where we observed 3 episodes of paroxysmal supraventricular tachycardia that were treated with adenosine. And after the second episode, we started continuous infusion of beta blockers. Now, on day 2, we actually found only a very brief episode, and we were very happy. We also treated that episode with adenosine, but we decided to liberate the patient from mechanical ventilation. So we stopped sedation, and you see, we extubated the patient. And at extubation, we started to have repeated episodes. And this is the 24 hours data presented in a row. So this occurred despite continuous infusion of beta blockers and calcium channels blockers. By observing the behavior of these 3 days, we took the decision, and the decision was also based in the 24 hours analysis of the blood pressure behavior. I draw a line which is dotted in blue at the level of 85 millimeters of mercury. And you see that in phase with those tachycardia episodes, there were significant hemodynamic depression. I mean, the patient went below 85 of systolic arterial pressure, which led in the end to consider ablation of left accessory pathway. And that is not something you do very easily in a patient in ICU unless you believe there is no chance. We were able to consider this opportunity because we reanalyzed the previous day's data. And 1 day after, the problem was completely solved, and the patient was stable without episodes of paroxysmal tachycardia and with a stable hemodynamic. There is another interesting opportunity. This is not a case report, but please look at this. One of the information you can receive is having a corrected QT duration, and you can have the maximum, the minimum, and the mean value. Why I think we should consider this as an important tool for our medical decision. You know that we use several drugs in our patients, and most of the drugs have a risk of QT prolongation, but in particular, we have a lot of risk of drug-to-drug interaction driving to QT prolongation. QT prolongation is risky because it increases the probability of having arrhythmias in our patients. And in this study, published 1 year ago by Becker and co-workers in the Journal of Critical Care, the authors found that the strategy to prevent this risk was related to the combination of 3 different aspects: clinical monitoring, breath by breath, beat by beat, I mean, immediate monitoring, avoiding combination of drugs, which is not always possible, and the EKG monitoring. Now, I believe that the information that we receive over a longer period of time, for instance, as soon as we interrupt a drug infusion, we don't observe maybe the change immediately, but is important to see what happens in a longer period of time. Last episode, I like this because of a fancy picture I will show you. This is a female, 35 years old. She received emergency surgery for hemorrhagic shock. The source was a splenic abscess with splenic artery erosion, left thoracic empyema with disruption of almost all the lower left lobe. The surgeons at the end of the procedure decided that the risk of postoperative fistula was too high to remove the lobe, and at the time of of the end of surgery, the leak was minimal and not really relevant from a clinical point of view. But few hours after ICU admission, the patient developed ARDS. And as you can see, over a period of about 3 hours, we observed an increase in the leak, leading to a major problem of hypoventilation. So in this condition, we had 2 chances, well, at least in my opinion, I might be wrong. One, put the patient in extracorporeal CO2 removal, we were able to maintain oxygenation, and we decided to follow the indication in these images in anesthesiology, where the author put a blocker of the bronchus to eliminate the source of the leak. Now, this is actually what we did. This is the patient. This is the X-ray. We put bronchoscopically, of course, the blocker, and we were able to isolate completely the left lower lobe. Now, in the upper part, you see with the color, the red part is what I showed you before, when the leak was huge. Then in blue, the point in which we position the beta blocker. The green areas are those where the leaks were controlled. And actually, we had to reposition 3 times the blocker because of during movement of the patient, we lost full control of the condition. However, we observed that in the 24 hours immediately after the intervention, we were able to have a reasonable leak, and we accepted to treat the patient without invading him with the echo tube removal technique. Last but not least, the possibility to use additional forms of monitoring. This is an old type of signal which is called perfusion, peripheral perfusion index, based on the ratio between arterial pulsatile and non-pulsatile vessels. And this was shown 20 years ago to be an interesting option for the clinician. However, only a few years ago, a couple of years ago, I was able to find a study which suggests a potential role, because in defining the risk of prolonged ICU stay, it was even faster than the measurement of lactate in recognizing patients at increased risk of prolonged ICU stay. Not only the perfusion index was able to predict an increase in the behavioral, I'm sorry, I missed an H in this slide, pain scale of 3 points. Now, this is our patient, my last clinical case. He arrived from the OR, he was cold and he required liquids. And he was extubated after he was warmed and filled with saline. And you see that over the following hours, the patient did pretty well. He was stable until 8 o'clock. And we see that the peripheral perfusion index drops, and the arterial blood goes up, and the heart rate goes up because of nursing. And again, this suggests that you might be able to detect periods where something happens, and sometimes it is useful to revise later on what you did, to learn from your wrong behaviors. Last My personal opinion regarding monitoring the future is related to the use of artificial intelligence, not to consider one specific physiologic type of data, but to merge together demographic, laboratory, and dynamic monitoring data to define some index which is able to consider, to alert about the risk of a patient to deteriorate or the risk of a patient of not being stable in the next day or two. This is an example, the artificial intelligence sepsis expert, which is based on collection and integration of all these data on a large number of data crunched by big computer, big devices. And as you can see from the tracing of this patient, the ACE score was much more early in detecting a problem related to sepsis in a patient, and it was much earlier than the SOFA score and 12 hours earlier than the clinical suspicion, which, in my opinion, indicate that this is something that will lead our clinical behavior in the future. And I wish to thank you for your attention.